Good morning. My name is E.Czerwinski. I am retired professor of Jagiellonian University and senior medical director in future medicine. I invite you to observe my presentation I had in Innsbruck on ETCS as invited speaker and was related to fracture healing and osteoporosis. Welcome. These are my disclosures. I am orthopedic surgeon and fracture management has been my duty of every day in my practice. I'd like to discuss physiology of fracture healing, problems of fracture healing in osteoporosis, medication osteoporosis, and just summing up. So, how the major fracture heals? Spinal fracture heals the best if we haven't seen the doctor. And proximal humerus just needs a sling, and this is no problem. Radius fracture is easy to have to be reduced, and unfortunately many complications, mainly the mine union. And the proximal femur fracture is a great issue, always the problem. Some of them we fix, and if there is some proximal neck fracture, it is for the total hip replacement. There's no doubt about it. From the textbook, we know that there are 4 stages of fracture healing. There's a hematoma. Today on the X-ray, we have just the break. Soft callus, 2 weeks, some cloud. Hard callus, the spongy bone, and we see on the X-ray, and then after 1 to 3 months, we have a remodeling of the fracture site. In osteoporosis, we have generally problems when the healing is usually 10 to 20% delayed and up to 40 complications. What means the delay? What is the definition? Is the duration longer than average? So here we see the femoral shaft fracture, and usually he's in for max 6 months, but here we see is the 8 months where we got the union. And non-union is the situation where the fracture without intervention will turn into pseudarthrosis. Like here after 10 months, we have definitely pseudarthrosis that means the bone moves in the side where it should move. As a physiology, so first hematoma, we have platelets releasing, hypoxia, inflammation, neutrophils, lymphocyte, macrophage, just the beginning of the normal healing. Like if you have a small cardiac heals and you don't have much, nature knows how to do it. Then we need soft callus, we need the bone cells, fibroblasts, chondroblasts, osteoblasts, and those comes from the mesenchymal cells, which are in the bone marrow and the perio and endosteum, and definitely blood supply, and we need, of course, angiogenesis. Then we have mineralization of the soft callus to hard callus and changing from cartilage to spongy bone, and we need blood supply and mechanical stimulation. And on the very end, bone remodeling, when bone osteocytes take care that the bone have appropriate quality. Why in osteoporosis you have delay of fracture healing? First of all, we have aging, we have osteoporosis, and low of no estrogens, and comorbidities. What is without discussion that we need two situations for fracture, I mean contact of fragments and blood supply. If none of them are existing, there will be never fracture healing. Local mean type of fracture, bone cells, cytokines, vitamin D, and general health status, bone health, comorbidities, diabetes, using steroids, and mechanical stimulation. And I like to stress that relaxation neuros in age is very popular, is unnecessary and maybe even harmful. Few words about aging. So starts from the bone microorgans, mitochondrium, which gives the energy, mitochondrial DNA mutation, ROS, ATP, some more less ATP production. Then stem cells are also weaker, smaller proliferation and reduced differentiation to other forms. Chondrocytes produces less cartilage, same osteoblast and slow osteocyte getting older and decreasation. And we need, of course, blood supply. Unfortunately, we have arteriosclerosis, mean less oxygen, less angiogenesis. So this was about why we have problems with fracture healing. And now, what about medication? I mean, bisphosphonates, denosumab, teriparatide, Romo, and then in summary. So always we have a beautiful results in the animal studies, and vitamin D definitely have to be in good level. And if you go to PubMed and you type fracture healing, you will be given 33,000 hits. If at the bisphosphonates is half of them, osteoporosis another smaller, and vitamin D is only 300. In animals, we see the osteoid formation, the control, quite nice. We see deficiency of osteoid formation in deficient, and if we supplement, we have again good quality amount of osteoid. So if we have good supply level of vitamin D, so the additional dose will have no changes, but in deficient they will. Studies in human being are rare. Meta-analysis, 14 papers, 2,070 patients, 8 studies assess the vitamin D, and 6 studies found no significant effect, but 5 positive effect. Bisphosphonates also beautiful study in animals. We have alendronate may slow down mineralization, so the callus is bigger. And we see we have the in rats saline, and alendronate quite bigger callus. In man is not so fine. We have studied randomized trial on alendronate, on reduced fracture, 400 patients, age 63, 217 alendronate, 200 placebo, and bone union was assessed on X-rays. And you see that there is no difference in any stage of fracture healing. About zoledronate, it is the core study for registration of zoledronate in osteoporosis, 2,127 patients, non-union, delayed union in placebo 2.7 and in Zol 3.2, but it was found that those differences were not related to zoledronate but others. Condition like NSH, which delays fracture healing with the coefficient 2.5. And here we have the study of meta-analysis of 60 studies, 5,000 patients, naltrexone, risdiplam, ibantonase, and we see that there is no any difference between placebo and zolendronate. Denosumab, similar issue. The Freedom Study, core study for denosumab registration. Denosumab delayed union, not 2 cases, just non-union 0, and placebo 4 cases. But I'd like to stress that the definition of delayed fracture healing was 3 months, and every radius will heal in 3 months, and non-tibial shunt with 3 months. So I think I will have some doubts about this criteria. And the other beautiful study, petrocalcaric fractures, and bisphosphonates denosumab, and there was no difference. What was found that doesn't matter when we give the bisphosphonates, even 2 weeks after the fixation, doesn't affect the fracture healing. We have many hopes that bone forming agents will accelerate fracture healing, but it was not true. Here is the meta-analysis for 5,000 patients, have included 1,045 patients, 500 fractures, all of the proximal femur radius, and we see that not any effect of the fracture healing between control and those who received teriparatide. The only difference was, in fact, of the pain. But we have more cheaper painkillers. And now romosozumab in rats, and you see the difference between placebo, quicker callus, and much stronger bone after the end of the fracture union. So it was very, very beneficial. And unfortunately, LCTs romosozumab, 332 patients show no really any difference. And the same meta-analysis, 14 studies, 300,000 patients, no any difference at all. So summing up, first of all, bone healing is a natural process of damage repair. It occurs in 4 phases, meaning hematoma, soft callus, hard callus, and remodeling. And stem cells submit the cells, chondrocytes and osteoblasts. Osteoporosis fracture healing is quite often complicated, up to even 40%. Delayed unit up to 20%, and even 10% of some cases may have problems with healing. The main cause of delayed union is the aging of cells and their organisms, and also deficiencies and comorbidities. Animal studies prove a very beneficial effect of bisphosphonates in bone healing by way of increasing the callus. Unfortunately, in patients, oral or intravenous administration have no effect, including zolendronate 2 weeks after the fixation. And in registration study of denosumab, no effect was observed in fracture healing. Administration of bone forming medication does not affect fracture healing in osteoporosis, but please remember that for efficient treatment of fractures is necessary to ensure vitamin D level by supplementation, exercise to improve blood supply, and provide mechanical stimulation, e.g. partial weight bearing. Saying I thank you very much for your attention. Thank you very much.